Welcome to Medscape. I'm your host, Dr. Andrew Wilner, reporting virtually from the 2023 American Academy of Neurology meeting in Boston, Massachusetts. Today, I have the pleasure of speaking with Dr. Nina Riggins, Associate Professor of Neurology at the University of California, San Diego, and a specialist in headache. Dr. Riggins is participating in a panel discussion at AAN on post-traumatic headache. Welcome, Dr. Riggins.
Thank you so much for having me here. Hello from American Academy of Neurology.
Yeah, well, thanks for joining us. So, I have a lot of questions. Of course, we see many headache patients, and now there is really so many patients with headache related to a head injury. And the ones that I see, we do the MRI and it looks fine, but they have headaches, and the headaches might last a day or a week or a month or 6 months. And it's really hard to kind of get a handle on a lot of these patients. And I want you to help me clarify the recommendations, because I remember we used to say, okay, the patients need to rest. Then no, the patients need to be active. And then it's return to play. When should they be active? Go back to school. They shouldn't use video games, but they can use video games. And so what are the recommendations now? For example, my nephew's playing soccer. It was a big play, ends up on the ground, he's dazed, and then he develops headaches every day. I'm sure you see similar patients. What do you tell them?
Yes. So post-traumatic headache is a big issue in our headache center. And we do have, as nephew, people of younger age who can develop headache which persistent even after mild traumatic brain injury. And it can be daily, it can be leading to different complications. One of those we usually address could be medication overuse headache. One of the things we have to consider when someone even have whiplash, that this person maybe have predisposition, genetic predisposition, or had migraine headache before, uh, and take little bit more of non-steroidal medications or any other pain medications. We have to really watch out for that. And then back to the question about return to play. We do want this person to be asymptomatic and not on medications for post-traumatic injury before this discussion of returning back. We would like them to be functioning well in school and at their work. And then we rediscuss return to play. So we want kids and adults to be very safe.
Okay, so number one, you got to be back to baseline
Yeah.
before you're going to risk banging up your head again. Is that what I'm hearing?
Yes, there is risk of repeat of brain injury, and we really want to make sure that we're not adding on. So we would like people be at the baseline before return to usual activity. How do we get to baseline is also a big question, right? I understand.
Yes, thank you. That was exactly where I was going with this. Okay, so how do we get them better?
How do we get them better? So at this point, we don't have FDA approved treatment specific for post-traumatic headache. So we have to go with what we already developed for types of headaches that they have that resembles most often migraine or tension type headache. So we likely know much more, and we use so many more treatments nowadays. I know very often our new classes of medications now used, such as CGRP blocking medications. We have big molecules and we have small molecules. So medication classes different and expanding, and we're extremely proud of that. But lifestyle is also so important. So extremely important to discuss with patients sleep. So regular sleep, very important. Some of articles even bringing up that napping during the day may be not as beneficial because it disturbs sleep cycle. Uh, Walking is excellent, so maybe increasing physical activity gradually. Uh, Headache likes regularity in meals and in hydration. So definitely hydrate, definitely eat regularly, sleep on time, and exercises. We enjoy exercises if patient can start walking every day and then gradually increase exercise. There is different rules and different articles. They propose monitoring. Uh, One of them is talking about 10-point scale. If you feel that your symptom going above 2 points up, any of the symptoms, scale back. But we likely and thankfully we don't anymore telling our patients just to lie down and don't do anything. So that's in our past. The activity, increasing regular physical activity as tolerated is very useful. I love exercises. We do have studies when patients, when they exercise, even for migraine 3 times per week for 30 to 40 minutes, it's comparable to our strongest medications. So, yes, for exercises. And we work very closely with our colleagues. Sport concussion, vascular neurology. I work with vascular neurology and vascular neurosurgery all the time. We're watching out for complications. We're watching out for new symptoms. One of the things could be tinnitus. And when it sounds like pulse, we really paying attention because sometimes during trauma, one can develop connection between different vessels, which not supposed to be connected. So we discover everything which can be pretty much fixed and we work together with our surgical colleagues on that. And then we have returned to play.
Okay, so it's really activity, a healthy lifestyle, right? Which
Mhm.
everybody should
Mhm.
do anyway, right? Eat right, sleep
Yes,
right, and then activity as tolerated. So you're not don't lie in bed all day, but if you're go for a long walk and you get dizzy, you got to go lie down. So it's really a common sense approach. It sounds to me for healing.
thank you. Yes, that's an excellent summary. And we do have other branch of treatments which I didn't mention. So we have medications, we have our lifestyle, and we do have devices. So brain injury can lead to multiple changes. It's person can be genetically predisposed. It can be axonal injury. It also can be neuroinflammation and different metabolic changes in the brain. So we do have devices which very interesting branch of literature coming out right now about few of them. One is vagal nerve treatment, actually being studied for post-COVID, long COVID. And they showing in articles now that inflammatory markers going down. So we have to wonder if some of our devices, and there are 5 FDA cleared devices on the market here now for treatment of migraine and some of them for treatment of different types of headache. If we can use them more widely and we try when we have migraine-like headache in person who had traumatic brain injury, we try migraine treatments. So
Okay.
yeah, we need more research for specific post-traumatic headache. But at this point, we do have electrical, magnetic stimulators, they call neuromodulation. And they have wonderful, usually, side effect profile.
You mentioned the vagus nerve stimulation. Is that the vagus nerve stimulator that I'm familiar with, the one that we use for epilepsy?
With epilepsy treatment, you actually have to do many more things than we doing with our vagal nerve neuromodulation. Ours is external.
Ah, okay. That's a big difference.
Yes,
That's a
yes.
big difference.
Mm-hmm.
Okay.
Yes, and it goes right here on the neck, and a person can titrate it up and down. And it's really approved for migraine, for cluster, and hemicrania. And now a few centers doing different post-traumatic and post-COVID research.
Let me ask you about, I've been hearing a lot about virtual reality. Are there any virtual reality programs for people with headache?
Absolutely. So there's big body of literature coming out about use of virtual reality for different post-traumatic syndromes and of course PTSD. We all using biofeedback very readily virtually, and it really works. It's published. Dr. Mia Minin, my colleague at American Headache Society, wonderful publications about use of teleheadache and about even muscle relaxation. And of course, we all familiar that there's few types of actions of virtual reality. One can be simply distracted from surroundings. It's sort of putting glasses or helmet. And they did research in waiting rooms and in infusion centers. It's really can take out a little bit of this component of environment which can be disturbing for patients. Um, to add to that, we do worry if person has migraine or post-traumatic headache with light sensitivity. We have to take it in consideration. We ourselves at UCSD running right now randomized control trial with glasses. It's not virtual reality, but it's blue blocking glasses. So randomly we assign different, one is placebo type of glasses and one block blue light special lens. And we enrolling right now, and people who qualify to be in the study would have brain trauma in the past. So I hope that at the one of the next American Academy Neurology conferences, we can present it in the future.
Oh, looking forward to that. So it blocks, the lenses block blue light. Is that right?
Right,
Versus
right.
letting all and well, in San Diego you've got a lot of light, so that's
Absolutely.
a lot of sunlight there. So you're gonna have to do pretty strong glasses. Well, I think we're running out of time. Is there anything you'd like to add?
Well, I want to say that screen time also play a role in what we do nowadays, right? And it brings up neck components. So I would
Hmm.
say don't forget about neighbor to the head and address any component, cervicogenic component. So to summarize, collaboration really matter. We have long way to go to study which treatments are the best. And that's why getting together here at American Academy of Neurology so wonderful. And thank you so much for highlighting this excellent American Academy of Neurology conference. It's big anniversary for us, and it's pleasure to be here.
Well, thank you, Dr. Riggins. I'm Dr. Andrew Wilner, reporting for Medscape. Thanks for joining me.